This next case is the endovascular management of a symptomatic cavernous internal carotid artery aneurysm. As is the case with many cavernous carotid aneurysms, this 43-year-old male presented with acute onset of diplopia. His neurologic exam demonstrated a mild left 6th nerve palsy. His family history was significant for a ruptured aneurysm in his father. Imaging demonstrated what appears to be a narrow-necked cavernous carotid aneurysm. Once the guidance is in place, intracranial angiography is performed in order to generate roadmap. The operator carefully selects a picture which separates the neck of the aneurysm from the parent vessel, as is demonstrated here. Here we can see that the wire and microcatheter are brought into the aneurysm, and as the wire is withdrawn under fluoroscopic guidance, the catheter then moves forward into the aneurysm. When catheterizing the aneurysm, one has to be sure to be cognizant of where the catheter tip is when withdrawing the wire, because forward momentum of the catheter can occur when withdrawing the wire. Once the catheter is in place, we like to position the tip midway into the aneurysm, not too close to the neck, not too close to the dome. Often, the catheter can herniate outside the aneurysm, and sometimes it is possible to climb the coil and bring the catheter back into the aneurysm, as is demonstrated in this technique. This is an advanced technique and should not be routinely tried. Occasionally, the catheter can skip past the aneurysm, as was seen there. Again, we will try to climb the coil back and deliver the microcatheter into the aneurysm. This is a complex maneuver and can result in coil herniation. If this can't be performed, the coil is then removed, often scrapped, and we bring the microwire and reset and bring the catheter back into place. At this point, we will try to get a deeper position of the microcatheter. And with a deeper position of the microcatheter, we see that there is more catheter stability. We can see how the coil nicely paints inside the aneurysm to develop a nice configuration and coil in a three-dimensional fashion. We tend to like to use fairly long coils as our first coil in order to get significant packing. Once the first coil is safely deployed, we then downsize our second coil, again trying to fill in gaps or lucencies in the packing density. We will continue to progressively deliver coils, moving from larger three-dimensional coils to smaller three-dimensional coils, coiling a basket in a basket technique or the Russian doll technique. After progressive downsizing of the coil, we will take spot angiograms in order to assess the packing density and continue to provide more coil packing until we're satisfied that we've reached sufficient density that the aneurysm is protected and will thrombose.